Natalie, welcome to Everyday Emergency. Just to start off, I wonder if you could introduce yourself to our audience and explain a bit about your journey with MSF.
My name is Natalie Roberts. I'm the Executive Director of MSF in the UK. I joined MSF in 2012, actually as an emergency doctor. Worked for a few years in our frontline projects as part of the emergency team. Then worked for a few years as the Head of Emergencies in our Paris office, followed by another few years working for the Crash, our reflection unit in Paris, and then I've been in this job now for about 2.5 years.
Fantastic. So a long career with MSF. For this episode of the podcast, we really wanted to talk to you about your time as Head of Emergencies. So obviously MSF is an emergency organisation. We respond to crises around the world. So I think some people might be intrigued or confused to know that we have what we call the emergencies team or the emergencies desk. I wonder if you could explain a bit about what that role is and how that team works.
So MSF actually always responds to crisis. It's actually in our charter. You know, we respond to people in crisis and we provide medical assistance and medical care to people in crisis. For me, the concept of emergency is about the mode of response. So we sometimes have to launch what's called an emergency response. And so sometimes responding to people in crisis, the emergency response mode is the right mode. And sometimes it isn't the right mode. The best analogy I'd take actually as a medical doctor is thinking about people who go into a hospital. So some people go into hospital, they need to see a specialist of their particular problem, they need to have a slightly longer term plan, they maybe don't need to go straight into the emergency department. But some people have an acute crisis, they may be having a heart attack or they've had a big accident and they need to go to the emergency department instead, and they need to go to the resuscitation room and be dealt with by emergency specialists who will look after them for a short period of time and really get on top of their acute crisis before stabilising them and handing them over to the longer term team. So for me, the Head of Emergencies, their role is essentially a bit like the consultant in the emergency department of a hospital. The Head of Emergencies manages what's called an emergency desk. So all the desks or cells or operational support teams, they're based in the offices and the operational centres, and they're all kind of overseeing projects and project teams working on the front lines. So it might be, for example, you have an earthquake or you have a typhoon in the Philippines. That will be very acute. You need to hit the ground running. You need to sort of be operational very, very quickly. It may also be that they intervene in places where MSF teams are already working, but there's been a new outbreak, an epidemic, or there's been a new peak of violence or a new crisis. So a couple of examples I'd give for that is Syria. So when the Syrian conflict kicked off in 2011, 2012, the initial intervention was run by the emergency teams, by the emergency desk. And that's because it was a very, very severe conflict, violence. It was a new place we hadn't worked before. And so we needed the teams that went there to kind of really understand what was going on, launch the intervention very quickly, and sort of being able to respond and set up activities extremely quickly. Over the last decade or so, actually, the Syria response has been more longer term planning. You know, there's been still the need, there's still people living in crisis in Syria, but it hadn't need to be managed by the emergency teams. But in 2023, there was a massive earthquake that suddenly hit northern Syria. Our project teams on the ground said, we need some extra support now. We need to respond in a different mode. And so the emergency team again got involved in northern Syria and took back sort of the intervention and launched additional activities to respond. So there's often a sort of relationship, you know, between the emergency desk and the other desks in places where we've been working for a long time. Sometimes it will be somewhere where MSF is not already working and the emergency desk needs to go in very quickly.
Okay. I wonder if you could take us through step by step what happens when you get that sort of sudden alert. So as you say, you're working in an office, you might be at one of the big MSF headquarters, and you get word, I don't know if it comes in via an email or a call, but you get word, there's been an earthquake, there's a sudden uncontrollable outbreak of cholera or measles. You get that alert that says, this is more than the team on the ground can deal with right now. What happens next?
So it depends on the situation, obviously. So something acute like an earthquake, you might be that you get the alert through, your phone. You might get an alert in the middle of the night. Something where actually a situation is just escalating, you've got an acute on chronic crisis. It might be that one of your colleagues comes along and says, I just want to talk to you about something. And then you have a conversation and you make that decision between yourselves about whether the emergency desk needs to intervene or not. So it slightly depends on the context, but usually then what you do quite quickly is you call a team meeting. You've got a whole team of people working with you, you sit them together, you find out what information you already know, and you start planning, okay, what do we need to do next? The first step normally is to get somebody on the ground, to get somebody there on the ground to understand really what's going on, because you can only understand so much at a distance. So when I was based in Paris, I'd identify one of my emergency coordinators, a member of my emergency team, and I'd get them on a flight as soon as possible to where they need to go so that they can start really evaluating the situation from themselves. Then you work in full sort of support mode and you're speaking constantly to that person on the ground. You might send them already with a team or supplies because you know that they're going to need to hit the ground running. But what you need to do is keep in really close contact all the time to understand what's going on and then to start planning for what do we need to do about that straight away. So the minute they say, okay, we're going to need to start doing surgery, then you need to kind of identify your surgical team to get them on a plane, send them out there. We're going to need to do an epidemic response. You start speaking to our logistics warehouse and saying, okay, we're going to need to order all the kits that we need to launch the epidemic response. We need the medicines, we need the supplies, and we start looking at how to get them onto a plane as soon as possible and get out there. It can be extremely kind of, particularly in something like an earthquake or a typhoon, where essentially it kind of feels a bit manic sometimes, but actually everybody understands their role. And it's, for me, the equivalent again of being a doctor in an emergency department. You have someone who comes in cardiac arrest. The minute you switch into that mode, every member of the team knows exactly what they're doing. They come in and check in with each other, regularly. We'll have kind of regular meetings during the day, even sometimes during the night. But then they'll go away, work on their thing, and then keep coming back in, checking again where we are with the process. Do we need to carry on with what we planned? Do we need to change what we planned? Your real kind of key informant, I guess, the person who tells you what we need to be doing is that person on the ground.
Okay, so that's a really key role. Can I ask, the way you're describing it, you've got this sense of you're always ready to hear about the next emergency crisis, and when it happens, you're talking about this sort of very fast-paced environment. What's it like to work on that desk and to sort of be part of that team? What does it feel like? Do you ever relax? Sort of.
Very rarely. I mean, you're a small team on purpose. You don't want to have too many people sort of sitting around. A lot of the job it's surveillance, really. It's keeping an eye on things. It's talking to your colleagues who are managing some of the longer term projects. It's kind of keeping tabs on what's happening in countries like the DRC or Nigeria, some of these huge countries where there's constant kind of crisis going on. So you're not always responding. Often you're just kind of keeping an eye on things and trying to make that decision of when is the right moment to step in. It can feel very, it can feel stressful at times. It can feel difficult to kind of make that right decision. Are we going to end up being too late? But with the mode of response that we have, you also don't want to be in there too early. You don't want to be sending in hundreds of people and destabilizing maybe a longer term project that was already running. So it can feel quite sort of stressful to kind of be making those constant decisions all the time and reevaluating your decisions. I really think though the fact you have this team, so this small team of, you have your logistics specialists, you have your human resource specialists sitting there, you might have some medical advisors around you as well. Your finance specialist is super important because they're the person who mobilizes the budget as soon as you need the resources. You all know each other very well. I mean, my team, when I worked in Paris, I'd worked with a lot of them when I was in the emergency team in the projects. And so we'd known each other a long time. So you kind of have that camaraderie of, they already know what I'm thinking. And so that can help as well because there's people sitting around you who really kind of have that experience of the same situation and who can deal with the stress of it as well. And who can recognize that sometimes in that peak of pressure, people don't always behave very well and they'll forgive you a little bit if you're a bit stressed and a bit agitated. It also means that when you have a quieter period, you also learn to give each other a break a little bit as well and make sure that people are taking their times off and getting enough sleep and not constantly checking their phone all the time. So it's important to have that team dynamic.
Okay, amazing. You mentioned several times as we've been talking this idea of sort of like as soon as possible, as quickly as we can, this idea of sort of once the decision is made to go, it has to happen rapidly. What sort of timings are we talking about here, and why is that important?
I mean, again, it depends on the context, but if it's something like an earthquake has hit and there's suddenly a lot of people who are injured, if we weren't already there on the ground, we're never going to be there to do that in the first few hours. But we want to be there as quickly as possible, because if there are people who are injured and we can still save their lives, then you need to be up and operating as soon as possible. So we do everything to prepare in advance, so that we talked a little bit about having a big red button. It was a symbolic big red button, but the moment we press that big red button, then there are no more delays. That as soon as we send people and supplies out there, as soon as they hit the ground, they can start working. So the quickest we can plan for is, once we decided to, say, intervene in a natural disaster, an earthquake or a typhoon, we get someone on a plane, we get the supplies on a plane. As soon as they land on the ground, they need to be interventional, including doing surgical intervention within 6 hours. Within 6 hours. So we developed a kit, and we spent quite a lot of time developing a kit. It's not perfect, but it's a kit of small inflatable tents, some medical supplies, and your trained team, so they're all familiar with those supplies. And then the backups you need, so things like generators and battery packs and things like that, to be able to start a surgical intervention, for example, after a natural disaster, after an earthquake, within 6 hours of landing on the ground. You just need to find a patch of ground, and you need to just start working with the team that you've gone with. Of course, then over the following hours, you need to find somewhere to put the patients afterwards, to keep an eye on the patients in the longer term. You need to start recruiting local staff to support you and to work with you, and you need to bring in your longer term sort of supplies and teams and start planning for the future days, weeks or months. But we can, in a real crisis situation, have people working within 6 hours of arriving somewhere. It's very rare that we would have to do that, though, because that's normally not the way we would have to intervene, but very exceptionally, if we have to, we could do that. Usually you want to take a couple of days to really understand where you are, to speak to the people who are responding locally. In anywhere there are people who will be providing support and care, and it doesn't matter how acute the situation is, it's best to understand really what's already happening around you before you start just diving in and doing things as MSF.
You've talked about having these staff who, when you decide you need to do a surgical intervention, for example, you call your one of your surgeons. When you need to take this kit, you call the logistics team. What allows the rapidness of that response? How do you know there's going to be a surgeon available? How can you make sure that this kit is... What facilitates this sort of speed?
So the emergency desk setup, you have this kind of core team based in the office, and for me it was in Paris, but you also have an extended team. So you have your emergency team, you have the headquarters based team, but you have the mobile team as well. So we would have a team of about between 15 and 20 people who all have a lot of experience, who speak multiple languages, who, as well as kind of having that training and experience of making rapid decisions, also are experts in what they do. So you might have, an emergency medic like me. I first of all, when I joined MSF, joined the emergency team because I was used to working as an emergency medic. You'll have emergency logistics specialists as well. So they know once they hit the ground, they know what's available to them, and they have then the team across, the operational centre. So they'll be in Paris, they'll be in our logistics warehouse in Bordeaux, they'll be elsewhere. They know who they need to contact and who can they mobilise. On top of having the human resources available to you, you have what we call our emergency stock. So again, that's based in our warehouse. We know what's in the stock. It's all sat there. If we need to get a generator, we know that there's a generator sat there. We don't have to order it from a supplier. It just goes straight out, gets put on the plane, and gets taken straight out there. And then the really key important thing that we have is what we called our emergency envelope, which is essentially a budget. You know that the money's sat there. You know that there's money that is available for that kind of emergency response capacity, that you don't have to kind of plan a project and then apply for the funding, that from day one you have the financial resources available to just be able to just go and know that you can tell your emergency coordinator, go, here's some money, here's how to access the money, you can start paying staff from day one, you can start recruiting staff from day one, you can start purchasing things locally, you can pay for accommodation, you can start recruiting drivers, you can rent some cars. And so it's really key to have those resources just there available. You know that you've got them to use immediately, and that's so important. I think we're so privileged as organisations like MSF because it is our independence of funding that allows that. We don't have to apply to a government or somebody else or a funder to fund a project. We can just, we have our donors who trust us. They give us money knowing that we will make the right decision with the money in that moment of crisis.
So that money is already there because of that trust.
It's already there, and we've already planned for the different scenarios we might have to face. If there's an earthquake in this situation, what will we need to do? If a conflict kicks off in the DRC or in Nigeria, what do we have to do? We've already planned those different scenarios anyway, and then we know that we just kind of roll them out as and when we need to.
You mentioned there that you have actually been on both sides of emergency response. So you've had this role which is office-based, which is really strategic and is about surveilling essentially the world and figuring out when this kind of fast emergency response is needed. But you've also had the experience of being one of those medics who gets a call potentially at quite short notice to say, this has happened, can you go? I wonder if you could talk about it a little bit from that side of things. Like, what is it like to be part of that on-the-ground team that might have to leave at very rapid notice, stop what you're doing elsewhere, and get out to this very rapidly developing crisis where you might not have a lot of information, I'm guessing, because things are evolving so fast. Yeah, what is it like to be on that side of things?
I mean, it was the part of the job I enjoyed the most, actually. I mean, I enjoyed working in Paris and it was nice and everything, but that feeling of being briefed and saying, okay, we're going to send you out to the Philippines because big typhoons hit, or we're sending you to Yemen or to Syria, and we want you to do what we call an explo. We want you to just decide what's going on and then tell us what we need to do. That was an incredible part of the job. And I think particularly back to my time in northern Yemen in 2015, where I was asked, we already had teams working in Yemen, but I was asked to go to the far north of Yemen where we weren't interventional. We didn't have anybody on the ground at that time. I was briefed of it's extremely dangerous. We know the bombing is extremely heavy up there. We think, we would like to support people living in that area. We're not sure if it's going to be possible because it's so incredibly dangerous up there. So I was essentially sort of briefed of, but we trust you, go along, you make the decisions, you decide if we can intervene there and what sort of intervention we can do and what's important. And it was such a privilege to be able to land in Sana'a. I recruited 3 Yemeni staff to come with me. People who'd worked for MSF before in Yemen, and they were willing to go up into the mountains in the north of Yemen and just go and start talking to people and understand what we were doing. And that's something that very few people get to do, to go somewhere like that and to really start engaging with the local doctors. Well, there were very few doctors working up there, but the health facilities, the medics, and just the kind of the people, and understand what was going on. And I was completely reliant on my 3 Yemeni colleagues because I didn't speak the language or anything else. But to know that I had that backup support, to know that the minute I needed to do something, that was coming, it's really important. So, I would be constantly on the phone back to Paris saying, actually, I think we need to kind of work in this health centre, we need to work in that health centre. I need these supplies. I need some more money, I need something. And to know that support was always there was really important to me. And also that level of trust, because what I said very quickly in Yemen was, I don't think we can do a massive intervention here. I think it's too dangerous to have too many people, suddenly coming in and having the way we did with the Philippines with the typhoon. We had a huge surge capacity. We sent lots and lots of people because we needed a lot of people on the ground. In Yemen, it was very different. It was, you need maybe 1 or 2 people who can really keep an eye on what's going on, but we need to really have confidence in and support what's going on locally and work with you know, the local medical facilities, and to have that trust from Paris to say, okay, we trust you, we trust that you're taking the right level of risk. That's really important, I think. You need to have that relationship going in there. You don't want someone questioning, you know, your evaluation, your decision making. And I think I really enjoyed that period of time working there, knowing that people had my back in Paris and were, you know, listening to me and responding to me and had confidence in me. And I think that's really important to create that, again, that culture of a team dynamic.
Absolutely, gosh. I wonder if you could say a little bit about, you know, one of the jobs of the emergency team is to go into unstable, developing conflict situations where things might not be predictable. Can I ask, how do you keep yourselves sort of safe, or perhaps a better question would be, how do you keep things as safe as possible when you're going into a dangerous situation like this?
We do a lot of training with our teams for security management, and what's very key is actually that we don't want people to fall back on this idea of, oh, okay, MSF will protect me, because you're going to places that are very volatile, very unstable. In fact, your protection, your security in those locations is about understanding what's going on around you. It's about making the right decisions. And so we can't train people to follow a guideline. What we do is we train people to evaluate, understand the situation, understand who's around them and who poses a risk to them, and maybe who can also protect them as well. And also to understand that, you know, our protection is really the benefit to the population. If people want us there, if we're providing medical care to people, then people will want to keep us there and they will protect us as well. So a huge amount of the training is about sort of negotiation, is about understanding the context. It's about making that risk analysis and adapting your risk analysis. We also really try and train people to not put themselves at risk unnecessarily. There's no point arriving somewhere, taking extreme risks, and then having either yourself or one of your team members injured or killed. You're just actually putting more of a burden on the local population. So a lot of the training we do with people is about saying, well, actually, what's the added value of being here? Can you do anything useful here? If it's too dangerous for you to be useful here, or if in fact, you know, you're putting yourself or your teams at extreme risk and actually, you know, in the end, you're going to cause more problems than good, then you should not be leaving that, you know, you should not be staying there, and we need to pull you out. So there's, again, a lot of dialogue and negotiation that needs to go in into understanding the risks around you. You can't control everything, but you really need to understand where you're working, and it's really key about experience and training, and really kind of having those local networks, speaking to your local colleagues, speaking to the people actually, and understanding really the situation you're working in. Gosh,
that's fascinating, and so many. It's really interesting to hear you talk about teamwork and knowing you've got the backing of all of MSF, but also knowing that you need to rely on your training and on your own skills to sort of navigate these spaces and to assess risks and just to think about like what's worth it and how you can look after yourself, and you're looking after a team as well, because you've hired these colleagues. I think we've got some clips of audio diaries that you made whilst you were in Yemen, so that's 2015, so this is 10 years ago.
10 years ago now, yeah.
Which I think we're going to play now.
I'm in the emergency room of a health centre that we've been supporting. It's up in the hills in the mountains of North Yemen, really quite near to the border with Saudi Arabia. It's an area that has heavy bombing on all the villages and towns nearby, sustained airstrikes most days. So we've come to implement an emergency room in this place. We've opened it inside a health centre. The health centre really it's pretty much the size of a British small GP practice. A couple of rooms, one doctor, and it's where patients would come just to have consultations normally for malaria, for normal illnesses. But since the conflict started, they've been seeing 40 to 50 wounded patients a week. And these are quite severe wounds. They're usually from airstrikes, so major injuries that need stabilising and referring for surgical intervention. Usually, every time I come here, there's blood all over the floor, and there's injured patients lying on all the beds, and they're often trying to manage what we call a mass casualty event, 4, 5, 6, 7 wounded patients all arriving at once.
At the time, the bombing in that area of Yemen was really pretty much indiscriminate. So all the hospitals and health centres I went to had been hit, but also the schools were being hit, the markets were being hit, and the roads were being hit. So what was problematic was that people couldn't access any medical care. So of course you had wounded patients, but you had the basics, like women who needed to give birth who were unable to access the hospitals. There were huge maternal health needs. People just couldn't travel on the roads to get to the hospitals or to get to the safer part of Yemen. The markets weren't running, people were starting to suffer from malnutrition. Essentially all the basic medical needs you'd expect anywhere, because the health system had pretty much been destroyed already, and that was within a few weeks or months of the bombing starting. So we found a huge number of medical needs, and really the biggest problem was access to healthcare. So what the biggest thing I think we did in Yemen was to hire some minibuses and convert them into ambulances, and we started picking people up and taking them to the health facilities because it was too dangerous to travel on the roads. And I think for me that's probably the most impactful intervention I've ever done.
I think that's an amazing example of flexibility as well, because if you'd gone in with a rigid, like we're MSF, we have to send a big team in, set up a hospital and provide this care ourselves, as you were saying, you're putting a lot of people in danger, perhaps unnecessarily. But with that sort of adaptable emergency mindset, there was a different way of responding to this crisis, which...
just about renting minibuses and paying drivers and labelling them as ambulances. I think we probably saved more lives than we would have done just sitting in one hospital and providing the surgical care.
I wanted to ask, you've spoken about, for example, countries like DRC, and we know that those are countries which have areas which are quite chronically unstable. There's a lot of things going on all the time. How is that managed? Because if you're having crisis after crisis, I imagine that you don't want to be sending in a team time and time and time again. Is it the same approach? How is that managed?
Yeah, so there's countries like DRC, Democratic Republic of Congo, Central African Republic as well, Nigeria. They are big countries. MSF's been working in some of those countries, DRC, well over 30 years. You know, they're in chronic crisis, but they constantly have acute crises on top. So in DRC, what will happen is there'll be an outbreak of measles or cholera, particularly outbreaks are happening, or there'll be a peak of violence somewhere, or a new population displacement. And as you say, you don't want to start having to look together for finding some international staff, obtaining visas, getting people out to the DRC. What we do in the DRC is we have local emergency response units. We've decided that, you know, the best people to respond are the people on the ground anyway. You don't want to, when you have long-term projects, maybe looking at HIV or maternal health care, you can't keep pulling teams away from their longer-term project to start responding to a crisis. So we have local emergency response teams who are constantly doing the same job as we would be doing in Paris, surveilling the DRC, understanding what's going on, devising their own scenarios for response, and then, you know, if a new measles epidemic, if there's rumours of a new measles epidemic in an area, they will get to that area quickly. They will start responding immediately. They'll evaluate the situation, decide what they need to do, respond. It might be for a few days, a few weeks, maybe even a few months of an intervention, and then they can close it up again. And, you know, and go back and wait for the next emergency. So essentially it's a local model of the global system that we also run as well. And those things need to complement each other. At times it might be, you know, DRC, they had a big Ebola outbreak. That's not something that the local team could respond to. It's quite exceptional. So at that point they flag it to Paris. But if it's a measles outbreak, they know very, very well how to respond to a measles outbreak. And in fact, they're the best people to be able to respond, often because they speak the local languages, they know the area, they know the local authorities, and so actually it makes a lot more sense to have a local response rather than an international response.
Mm-hmm. Can I ask, what sort of personality do you need to be part of the E team or work on the emergency desk?
I think emergency responders need to be quite resilient, as you mentioned before. You know, it can be quite stressful. You're kind of constantly having these boosts of adrenaline. It can often be very stressful for people to not be able to plan in the longer term because you constantly have to adapt all the time. So that personal resilience needs to be there. I think another really key thing is curiosity. You do see people, we see it again in the NHS, we see it, you know, anyone who's constantly having to kind of is exposed to crisis and respond to crisis, they can end up becoming a little bit jaded, a little bit kind of, you know, formatted of, oh yes, another epidemic will just do it. I think that kind of nature of constantly being curious, thinking, well, we tried this last time, it didn't quite work, let's try something a bit different this time, you know, being a bit creative and inventive. I think it's still really relevant in there. I think the other key point is also knowing when to not do an emergency response. And I think it can be easy when you have a hammer to see everything as a nail. And sometimes I can see that when I was in the emergency team, and particularly when I was head of emergencies, of, well, everything warrants an emergency response. I think it's really important to also say, well, actually, sometimes, you know, if you have a sick patient who comes into the emergency department and you take them to resuscitation, it's actually quite invasive and it can be quite harmful. So it also is that decision making of, actually, I think it's not for us to respond, and to say no at times, I think is also very important. So to still kind of not have the arrogance of, we're the emergency team, we're the best. Actually, sometimes an emergency response isn't the best model to do, and you're just part of the bigger ecosystem around you. So some humility, I think, still needs to be there amongst emergency team members, and particularly if you're in that role of being the head of emergencies as well.
Yeah, absolutely. I wonder if you could, for our listeners who are sort of thinking about, you know, maybe they follow MSF, maybe they get dispatches, our supporter magazine, so they've seen about some different MSF projects. What would be the sort of big MSF responses which at the moment might be being run by the emergency team?
Well, clearly at the moment, I mean, we're seeing huge peaks of violence, conflict in places like Gaza and Sudan. So Gaza, we would like to do more. It's just so dangerous and it's so difficult to access. But it's still a huge response that we're doing in Gaza. We would just think it warrants an even bigger response if that was possible. Sudan is a huge catastrophe. You know, it's horrific across the entire country, and particularly in Darfur. So that's one of our bigger responses right now for violence and conflict. There are other places that go a bit more under the radar. So the situation with malnutrition in the north of Nigeria, it's now been well over a decade that we have been seeing huge levels of malnutrition in the north of Nigeria, and we are still responding, often in emergency mode, in some of those places. And it sometimes just goes under the radar when you're sort of faced with, you know, catastrophes like Gaza and Sudan. But we need to not forget that there's also huge responses in north of Nigeria, in the Bangladesh with the Rohingya population, in the DRC that we've talked about. And so a lot of those places, the emergency team is involved, even if we've ended up being in the north of Nigeria responding to malnutrition for now 10 years, it's still relevant that there's an emergency response mode going on.
Fantastic, thank you so much. Is there anything else that you feel like our listeners should know about emergency response within MSF that we haven't talked about yet?
Let me think about that. I mean, I think it's this idea that really emergency response does take, you know, we always sort of say it takes a village, but it really is so dependent not just on the emergency team. It's really dependent on the local colleagues, and it's actually really dependent on the population where we're working. No emergency response can be successful if the population doesn't really understand what you're trying to do and doesn't kind of come around and support you in that. So emergency response, you might only see the person who's come back from somewhere like Gaza and Sudan who talks about their experience. What they can't talk about is the experience of our patients and the experience of the people living in that environment. And we can try as much as possible to talk about that. But when the emergency response finishes, and the team pulls out, or maybe even sometimes MSF pulls out, it's still the local population, the local communities that have to kind of pick up the pieces and move forwards with their lives. And I think it can be difficult to see that sometimes when you read dispatches, you know, what happens after the emergency response, I think is something that it would be nice for everyone to think about a bit more.